tapi hasilnya Ladies and gentlemen, please welcome Director General of Advanced Health, Ministry of Health of the Republic Indonesia, Mr. Azhar Jaya. Good morning, ladies and gentlemen. Before we begin today's program, let us rise together to sing our national anthem, Indonesia Raya. We kindly ask all attendees to please stand up. Thank you. Thank you. You may now be seated. Now, ladies and gentlemen, let's take a look at the fetal maternal journey video.
Recording in progress.
So that was the video about fetal maternal journey. And then next, let's listen to the welcoming remarks from the Director of National Women and Children Health Center, Harapan Kita Hospital, and Chairman of Cimfm. We invite Mrs. Sadina Pramuktini Besar to please come up to the stage.
Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua. Om Swastiwastu, Namo Buddhaya, salam kebajikan, Rahayu. Good afternoon. It's a great honor for me to welcome all you to this important seminar. Allow me to first extend my highest respect and warmest greeting to the Minister of Health represented today by the Director General Advanced Health Services, Mr. Azhar Jaya, Her Excellency the British Ambassador represented by Miss Julia Robertson Takahashi, Health Advisor and Head of the Health Team, the President Director of National Women and Children Health Center Harapan Kita, Mrs. Okti Palupi Rahayu Ningtyas, along with all members of the Board of Direction, our distinguished guests from UCLH, and all honorable participants. It is a true honor to welcome you all this special occasion, where we celebrate the collaboration between National Women and Children Health Center, Harapan Kita, and the University College London Hospital. The partnership reflects our shared commitment to advancing education, healthcare services, and research. Together, we seek to improve patient care and contribute to medical progress that benefit both nations. At National Women and Children Health Center Harapan Kita, we are especially proud to the progress we have made in maternal fetal medicine as a national referral center for high-risk pregnancies. This very initiative was first proposed by our maternal fetal team, whose vision and dedication have made today's collaboration possible. Through this partnership, we look forward to expanding opportunities for training, improving outcome for mother and children, and conducting joint research that will have lasting impact. Excellencies, ladies and gentlemen, this collaboration is not only an institutional agreement, but also a symbol of friendship and shared vision between Indonesia and the United Kingdom. Seen on the screen, the distribution of the participants of this event coming from all over Indonesia and also from Malaysia. On behalf of National Women and Children Health Center Harapan Kita, I extend my heartfelt gratitude to the Minister of Health, to the UK Ambassador, and our colleagues at UCLH for trust and support. Thank you.
Thank you very much, Mrs. Sadina, for the opening speech. Now, we are about to present a video about fetal maternal team and their healthcare services.
Pelayanan fetal maternal di Rumah Sakit Harapan Kita mencakup fetal diagnostik dan fetal terapi. Fetal diagnostik diantaranya adalah mendeteksi kelainan bawaan selama di dalam kandungan dengan menggunakan ultrasonografi. Kelainan yang dapat ditemukan adalah kelainan pada organ kepala, organ toraks, abdomen, ekstremitas. Deteksi kelainan jantung dapat dilakukan dengan melakukan pemeriksaan fetal ekokardiografi. Selain dengan menggunakan USG, kita dapat mendiagnosa kelainan di dalam kandungan dengan melakukan pemeriksaan kromosom, yaitu dengan melakukan tindakan amniosintesis dan melakukan kordosintesis. Fetal terapi yang dilakukan di Rumah Sakit Harapan kita, amnioinfus adalah untuk memasukkan air ke dalam kantong amnion pada kasus-kasus di mana air ketuban sangat sedikit. Amnioreduksi dilakukan pada kasus-kasus polihidramnion. Fetal terapi yang dilakukan di Rumah Sakit Harapan kita adalah fetoskopi. Fetoskopi ini dilakukan pada kasus-kasus twin-to-twin transfusion syndrome. Kemudian kita juga melakukan umbilical cord occlusion. Ini dilakukan pada kasus acardiac twin. Pada kasus-kasus di mana denyut jantung janin yang cepat, kita memberikan injeksi langsung ke dalam perut janin. Transfusi intrauterin kita lakukan pada kasus-kasus fetal anemi. Fetal anemi bisa kita diagnosis selama bayi masih di dalam kandungan dengan pemeriksaan USG. Pemasangan fetal atau shunting kita lakukan pada kasus-kasus dengan megafisika, kemudian pada kasus hidrotoraks.
Okay, after we watch the video of fetal maternal team and their services, I would like to invite Mrs. Julia Robertson, Health Advisor and Head of Health Team UK Embassy Indonesia, to come up to the stage.
Yeah, it's okay. Thank you. Assalamualaikum. Shalom. Om Swastiastu. Namo Buddhaya. Salam kebahagiaan dan salam sejahtera. Hopefully next year my bahasa Indonesia is going to improve. And selamat siang, Bapak, Ibu dan Dokter sekalian. Director General of Advanced Health Services, Mr. Ashar Jaya, President Director of Harapan Kita National Women and Children Health Center, Dr. Okti Palupi Rahayun Kitias, University of College London Hospital professors, specialist doctors, representatives and from hospitals. It's a great honor to be here today at this pivotal workshop and symposium of maternal fetal medicine. I would like to thank Harapan Kita National Women and Children Health Center for the kind invitation and for convening such an important event. The Indonesian government is advancing maternal and child health through key initiatives, including the triple elimination program and expand midwife training as well. Indonesia continues to strengthen maternal and child health through improved services, delivery, data-driven interventions, and community outreach. The Health Transformation Agenda, launched in 2022, enhances primary care or puskesmas capacity and promotes regional equity. Telemedicine and mobile health teams are expanding access in remote areas. These efforts support national targets to reduce maternal and child mortality, and accelerate progress toward universal health coverage and the 2030 Sustainable Development Goals. The United Kingdom brings world-class expertise in maternal fetal medicine, from advanced prenatal diagnostics and fetal interventions to genetic screening and high-risk pregnancy management. Institutions like University College London Hospital are global leaders in this field. Their presence here today is a testament to our shared commitment to improving outcomes for mothers and babies. We are enthusiastic about our commitment to holistically upgrade the health professionals' skills through the midwife capacity advances for equitable sexual and reproductive health and reproductive rights projects, or MARCH, from UNFPA. This project, launched in early 2025, will empower midwives and enhance the profession's regulatory framework, building a strong cadre of skilled healthcare professionals who can deliver high-quality, evidence-based care. It's inspiring to see comprehensive approach being taken by all healthcare professionals and facilities to support the national strategic agenda, particularly in advancing skills within fetal maternity specialties. Today's symposium represents another significant milestone in the UK-Indonesia healthcare partnership. It is an opportunity to deepen our collaboration, align our strength strategies, and build sustainable partnerships that will benefit generations to come. The UK government stands ready to support Indonesia's healthcare transformation, not only in maternal fetal medicine, but across the broader innovative health systems. Together, we can ensure that every mother and every child receive the care they deserve, regardless of where they live or their socioeconomic status. I'm proud that the UK expertise and innovation can be such a close partner of the government of Indonesia as we work together to strengthen your health system. Thank you for the opportunity to be part in this inspiration symposium and workshop. I wish you all a productive and impactful symposium. Terima kasih.
Thank you so much, Mrs. Julia, for your opening speech. Now we are going to watch another video. It's about preeclampsia that received an award from World Health Organization in 2022.
Kebanyakan kehamilan berlangsung indah, namun ada juga yang tidak sesuai harapan. Seorang guru kami mengatakan kehamilan itu seperti kondisi saat hujan. Kadang berakhir pelangi, kadang berakhir petir dan badai. Salah satunya adalah preeclampsia. Ini adalah cerita kehamilan kedua Ibu Dian, di mana di kehamilan pertamanya, bayinya meninggal di dalam kandungan saat usia kehamilan 28 minggu akibat ibu ini mengalami preeclampsia.
Tensinya ternyata nggak turun-turun kan, setiap cek nggak turun, sampai akhirnya tambah naik tuh. Sebenarnya awalnya mau cek, ini udah mau trimester 3 kan, ulu hati itu sakit. Terus kita ke klinik, ternyata tensinya udah 160/100 gitu. Langsung dirujuk untuk rawat inap gitu. Nah, selama rawat inap itu ternyata makin parah gejalanya, udah pusing, udah mata kunang-kunang seperti itu. Yang gejala khas preeklamsia kita tahu ya, pas udah selesai itu kan kita langsung cari tahu, oh emang ini ternyata gejalanya.
Preeklamsia adalah kondisi di mana seorang ibu hamil secara tiba-tiba mengalami tekanan darah tinggi pada usia kehamilan di atas 20 minggu yang dapat disertai dengan gangguan fungsi organ lain ibu maupun pada pertumbuhan janinnya. Preeklamsia merupakan salah satu penyumbang angka kematian ibu hamil dan bayi tertinggi di dunia. Sebanyak 76.000 perempuan dan 500.000 bayi meninggal akibat preeklamsia setiap tahunnya.
11 sampai 13 minggu itu di USG, terus cek darah juga ya. Itu buat screening untuk ngecek berapa besar kemungkinan kejadian preeklamsia ke depannya. Cek aliran darah ke plasenta dari yang di perut itu, USG-nya.
Kejaninnya efeknya apa? Dia kecil bayinya, ya kan? Terus ya bisa juga sewaktu-waktu dia nggak ada yang kayak riwayat yang pertama itu, ya kan? Nah ke ibunya seluruh organ, Pak, seluruh organ dia bisa dipengaruhi, mulai dari kepalanya, otaknya, ya kan, pembuluh darahnya. Karena racun ini kan dia beredar di pembuluh darah, jadi dia disirkulasi baik ke ibunya maupun ke janinnya, gitu. Nah makanya ada preeklamsi yang kena ke ginjal, jadilah dia proteinnya bocor di situ, ya kan, di urinnya tuh ketemu protein kan dulu kan kalau preeklamsia. Terus di otaknya bisa suatu saat kejang kayak gitu-gitu. Nah, sampai saat ini sih alhamdulillah semua terkontrol, ya kan, pertumbuhan bayinya oke, ya kan, ibu tekanan darahnya oke. Hasil-hasil lab juga sejauh ini insya Allah baik. Nah mudah-mudahan nih sampai nanti 38 minggu semuanya oke, Pak. Bismillah ya Bu, mudah-mudahan lancar ya. Ya ini kita udah berjuang, tinggal kita serahkan sama Allah lah ya. Yang penting kita udah usaha, tinggal hasilnya kan udah ada yang ngatur Pak ya.
Sebenarnya yang paling dikhawatirin itu kalau tensinya naik sih. Nah, sampai sejauh ini sih masih normal-normal terus. Itu udah lebih tenang sih kalau itu, karena udah terpantau.
Sampai saat ini kehamilannya sudah 36 minggu. Dan alhamdulillah sejauh ini kondisi bayinya dalam kondisi baik, pertumbuhan bayinya baik, ibunya juga dalam kondisi baik, tekanan darahnya terkontrol, dan sampai saat ini tidak ada tanda-tanda gangguan di organ-organ ibunya. Dan kita akan mempersiapkan untuk persalinannya secara sesar di usia 38 minggu.
Ya harapan saya ya anaknya sehat sih, sama istrinya juga sehat ya. Persalinannya juga lancar nanti, nggak ada kendala apa-apa sih, itu aja sih.
Pada akhirnya, malaikat kecil yang dinanti menjadi pembawa kebahagiaan untuk keluarga mereka. Meskipun peristiwa yang lalu masih memberikan luka yang teramat dalam, yang tak bisa dilupakan.
So moving on to the next agenda, please join me in welcoming the representative from the Ministry of Health of the Republic Indonesia, Director General of Advanced Health, Mr. Azhar Jaya. Please come to the stage.
Baik. Assalamualaikum warahmatullahi wabarakatuh. Selamat sore, good afternoon, salam, om swastiastu, namo buddhaya, dan salam sehat. Distinguished guest, Ambassador of the United Kingdom to Indonesia was represented by Health Advisor and Head of Health Team UK Embassy for Indonesia, Miss Julia Robertson Takahashi. Japanese people, yeah. Of course, distinguished professor from University College of London Hospital, Professor Pranav Pandya, Professor Jan Depres, I'm so sorry if I'm wrong to call your name, Associate Professor Sarah Hillman, and Associate Professor Rafael Napolitano, Italiano people. Okay. And President Director of RSAB Harapan kita with the team, all professor and all participants, ladies and gentlemen. First of all, I will to apologize because our ministry, Pak Budi Gunadi Sadikin, cannot attend this meeting because he have the other agenda with our President, Bapak Prabowo Subianto. Saya mohon maaf, saya speech-nya pakai bahasa Inggris, jadi kalau yang bukan masalah sok tahu ya, tapi karena diminta sama Bu Okti bahasa Inggris gitu loh, ya. Jadi saya mohon maaf ya. Okay. Ladies and gentlemen, it is an honor to welcome you to the collaborative innovation in maternal fetal medicine workshop and symposium. I would like to thank RSAB Harapan kita for organizing this event, which foster important collaboration with University College London Hospital, UCLH. Ladies and gentlemen, maternal and child health remain one of Indonesia's greatest challenges. In 2024, around more than 4,000 mothers lost their life due to pregnancy-related causes. Infant mortality also remains a concern, with more than 26,000 babies dying before their first birthday. Among the leading causes are congenital malformation, deformation, and chromosomal abnormalities, which account for 9.2% of infant deaths. Two major challenges contribute to this outcome. First, the shortage of qualified human resources. Only a limited number of obstetricians with fetal-maternal subspecialties and clinical geneticists are available, mostly concentrated in major cities. 14 out of the 38 provinces still lack a fetal-maternal subspecialist. Second, early detection remains suboptimal. Effective early detection not only identifies problem, but also uncovers opportunities for timely intervention, optimize care planning, and improve life trajectories. This requires access to advanced technology such as PCR and NGS. Ladies and gentlemen, responding this situation, the Indonesia Ministry of Health is intensifying its effort to enhance services quality through key initiative. The standardization of integrated antenatal care, or ANCT, with 6 quality contexts, supported by the fact that more than 9,000 of the more than 10,000 puskesmas, or 95%, now have ultrasound machines. This is complemented by integrated early screening for preeclampsia, anemia, and triple elimination, HIV, syphilis, and hepatitis B, and strengthened by technology support through the Satu Sehat digital platform and the strategic deployment of the 271 PCR machines and 12 NGS units for advanced prenatal diagnostic. All of this is reinforced by the nationwide standardized training to build healthcare worker capacity. Ladies and gentlemen, addressing maternal and child health challenges requires strong collaboration. The Ministry of Health cannot do it alone, and international partnership are essential. RSAB Harapan Kita, as the National Center for the Maternal and Child Health, has partnered with UCLH to promote knowledge transfer, strengthening clinical skills, and expand services network. Through this seminar, we support innovation in maternal fetal medicine, including INC standardization, fetal therapy, and prenatal genetic testing. This partnership exemplifies how RSAB Harapan Kita contribute to the government health transformation agenda towards zero preventable maternal and infant deaths. Ladies and gentlemen, life began with infinite potential in the world, and early detection can optimize it. So let us use this event as a platform to convert these opportunities into meaningful action by strengthening partnership, sharing knowledge, and advancing clinical practice. Together, we can ensure that every mother and child receive timely, effective care, shaping healthier future from the very start of life. Thank you very much for your attention.
Thank you so much, Mr. Azhar, for your encouraging and inspiring words. I would like to ask you please remain on this stage because next agenda is opening ceremony, and I would like to invite Mrs. Sadina, Mrs. Okti Palupira Hayuning Tias, and Mrs. Julia to come up to the stage. Okay, the ceremony will be performed by placing our hands on the screen behind you. Yep. Placing our hands on the screen simultaneously. Okay, ready? Hands on the screen. Let's begin the Cimfm 2025 opening ceremony. 3, 2, 1. Maternal Board of Director of National Women and Children Health Center Harapan Kita Hospital, Health Center Harapan Kita of National Women and Children, UCLH member to come to the stage to take picture together. And also fetal maternal team member, please come to the stage. Thank you. Okay, are we ready, everyone? Okay, 3, 2, 1. Smile, 1, 2, 3. Let's one more time. 1, 2, 3. Okay, thank you, ladies and gentlemen. And next agenda is I would like to inform you that on my left side we have exhibition Innovation Team Fetal Maternal National Women and Children Health Center Harapan Kita Hospital. Here we have some of the tools that we usually use in our learning activities that Dr. Aditya will explain the function and operation of these devices. Mr. Azhar, Mr. Okti, Mrs. Sadina, Mrs. Julia, and Dr. Aditya.
Beberapa publikasi gitu ya, dari 2018 sampai dengan sekarang kami publikasi dan ini hasilnya kami bisa menurunkan angka preeklamsia sampai 80%, preterm 18%, fetal growth restriction 42%. Sebenarnya semua saling menunjang, tapi satu yang memang masih belum menjadi suatu rutinitas adalah pemeriksaan darah, namanya PLGF, placental growth factor. Itu yang kami lakukan. Ya lumayan, tapi sekarang harganya makin lama makin turun, harganya sekitar 300-500 ribu antara itu. Tapi itu sangat pada akhirnya kita melakukan cost effectiveness study dan pada akhirnya itu sangat potensial menurunkan biaya kesehatan. Ya, memang kelihatannya lebih awal di awal, tapi pada akhirnya kita akan menurunkan angka prematuritas, ICU, NICU yang luar biasa masif itu. Pada dasarnya semua wanita hamil di usia 3 bulan di 12 minggu, artinya yang mereka yang belum menunjukkan gejala apapun, kami universal melakukan pemeriksaan kombinasi. Sebaiknya pakai ini. Betul, dan ini betul. Jadi artinya ini kami juga melakukan beberapa publikasi bersama dengan penelitian kolaborasi dengan beberapa negara Asia dan hasilnya seperti ini gitu, Dok. Bisa menurunkan 80%. Betul. 500 ribu. Ya. Harga satu pemeriksaan, tapi itu kalau nggak lebih murah sekitar bisa sampai 300 ribu per orang gitu. Ya, betul.
Nah, pemeriksaan bisa sampai puskesmas. Yang mampu untuk melakukan pemeriksaan itu siapa?
Sebenarnya ini kalau misalnya kami dengan program pengampuan pada dasarnya kami bisa diseminasi sampai dengan layanan setidaknya di SPOG itu kami bisa, tapi nanti di slide selanjutnya kami akan sampaikan strategi kami dengan primer gitu. Ini yang kedua, ini kami dibantu dengan teman-teman dari ITB, kami kolaborasi ya dari ini mereka 1, 2, 3, 4 ya mereka ya masih muda-muda, mereka luar biasa inovasinya. Ini belum pada menikah nih. Iya. 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 Ini mereka semua insinyur gitu ya, mereka semua sarjana teknik. Jadi mungkin silakan cepat saat ini kita sampaikan.
Iya, kita ini bisa bridging gap, Pak. Bridging gap, memang kan sekarang banyak materi ibu dan anak, kita pengen nggak cuman mungkin yang punya skill set yang baik, spesialis atau spesialis, kita bikin dengan cara mudah, cukup dengan swipe, dengan protokol seperti ini, 1, 2, 3, 4, 5, 6, nanti dari bidan ataupun health worker bisa melakukan, kemudian akan terdapat indikator warna seperti hijau, kuning, atau merah untuk apakah saya perlu rujuk atau tidak. Jadi hanya menunjukkan early prediction saja gitu Pak. Bapak mungkin mau lihat kalau di sini.
Ini proofnya udah ada di USG yang di puskesmas atau di USG?
Belum ada Pak. Kami lagi development ongoing tapi sudah mulai Pak buat kita gather data dan juga akhirnya Pak dapat validasinya juga. Jadi dari sini aplikasinya mungkin bisa dilihat.
Enggak, kalau begini kan sekarang udah banyak nih.
Betul Pak. Yang berbeda ini Pak, mungkin Bapak bisa lihat. Jadi mau bidan maupun nanti dari health worker, kami tinggal klik mulai sisir, ada instruksinya, cara penggunaannya seperti apa, klik lanjut. Betul Pak, nanti akan langsung swipe sesuai dengan protokol yang sudah back dari scientific kita. Betul, tinggal lanjut, 1, 2, 3, 4, 5, 6.
Ya ini kalau dari beberapa paper bisa sampai di atas 85%.
Betul Pak.
Kami saat ini sedang collecting data dan nanti dalam waktu yang didalami kami akan mempublikasi hasil kami gitu.
Oke. Berapa sekarang pertanyaan? Ujung-ujungnya kan UUD-nya ya?
Iya, nanti di akhir tahun kami akan sampaikan, kami akan laporkan hasil semuanya termasuk cost analysis yang kami akan sampaikan.
Jangan mahal-mahal.
Tidak sih.
Ya, Pak,
Demi bangsa dan negara nih.
Ini kalau bisa disebar puskesmas, kalau luar biasa. Mudah-mudahan
Itu indikatornya Pak, hijau, kuning, dan merah.
Begitu di swab gitu ya, langsung keluar begini kan gitu ya?
Iya, kita pakai AI teknologi buat langsung prediksi seperti ini Pak.
Berarti
6 kali swipe ibu.
6 kali gerakan gitu ya?
Kita tidak mengajari bidan USG, tapi mereka hanya dengan 6 kali gerakan, mereka akan dapat laporan seperti ini.
Oke, bagus. Cuman bisa nggak dikembangkan, mohon maaf, kita kan sudah deploy USG banyak ke puskesmas.
Dia bisa dihubungkan itu insya Allah bisa.
Nggak apa-apa, nanti cipta Anda kita beli gitu loh. Tapi bisa built in dengan proof yang ada di puskesmas.
Kita bisa bicarakan lebih baik.
Kalau kita harus beli ini lagi agak repot ya.
Betul Pak.
Karena nanti pengadaan lagi repot saya. Tapi kalau misalnya bisa di proof in, Anda hak paten kan pemerintah beli.
Insya Allah Pak.
Ya kan begitu ya kan. Ya kan kita harus hargain dong gitu ya. Cuman ya itu tadi, manfaatkan alat yang ada kalau bisa. Ya.
Siap.
Cuman kalau nggak bisa Anda harus ngomong, kenapa kok nggak bisa. Ya.
Siap Pak. Yeah.
Oke, good. Kalau misalnya ini lumayan nih, bisa nurunin itu ya. Iya, angka kematian berapa? Itu sekali aja cukup.
Iya, sekali aja.
Sekali aja. Oh.
Ada videonya mungkin Mas?
Oke.
Yang ini.
Videonya bisa diputar kayak gitu.
Gambar Pak.
Oh, gambar.
Iya. Itu yang dia ada bakal di guide saja, jadi kayak kita tinggal guide saja.
Ya, saya paham. Gampang. Begini gitu ya.
Pak.
Terus nanti keluar hasil ya kan gitu ya.
Betul Pak.
Oke. Ya, mudah-mudahan
ya. Pak.
Kapan selesainya?
Kami Pak Dokter.
Sedang koleksi data, nanti itu tadi yang kami akan sampaikan performance matrix-nya. Nanti kami akan segera laporkan.
Oke.
Ya.
Saya tunggu ya.
Siap Pak.
Ya. Ini karya anak bangsa ya.
Ya, betul.
Good. Ya. Seneng nih saya nih. ITB berkolaborasi dengan kita di kesehatan itu.
Amin Pak, mudah-mudahan.
Seharusnya dari dulu. Ya, oke. Yuk. Oke.
Yang ketiga?
Yang ketiga ini adalah kita juga mengembangkan, kita mencoba diseminasi apa yang kami pelajari, apa yang kami dapat di Harapan kita. Ini ada beberapa teaching gitu. Jadi seperti ini bagaimana kami melakukan fetal intervensi gitu ya, bayi dalam perut. Dr. Nurwansyah juga dikembangkan, ini adalah apa namanya, dengan yang alat yang relatif diseminasi untuk penggunaan alat pelatihan. Begitupun juga dengan ini yang mungkin ini kita besok sama-sama belajar, kita mengundang dari Inggris dan dari Belgia. Ini adalah spina bifida, jadi nanti kita akan coba bekerja sama juga dengan bedah saraf. Bagaimana nanti proses ini, apa itu namanya, manekin model seperti ini bisa jadi latihan kita untuk sebelum kita terjun gitu. Jadi artinya kita banyak mendevelop alat model training dengan biaya yang murah, tapi kita mencoba bisa diseminasi ke banyak.
Ini spina bifidanya mau ngapain?
Ini nanti spina bifidanya ini kita akan misalnya kita akan penutupan gitu. Jadi ketika dia di dalam janin gitu, ketika dia masih dalam perut, karena kan kalau seperti ini air ketuban itu akan toksik untuk masalah persarafan. Khawatirnya dia nanti akan lumpuh dan seterusnya. Jadi diharapkan dengan kita bisa melakukan closure, penutupan lebih awal gitu ya. Biasa kita lakukan di 18 minggu itu seperti itu 24. Nah, itu kita harapkan bisa menurunkan morbiditas untuk bayinya.
Tutupnya pakai apa?
Nanti kita besok sama-sama akan belajar dari para tamu kami, bisa pakai alat bantu fetoskopik gitu, dan juga kami bisa juga dengan skenario lain mungkin kita buka gitu. Gitu. Jadi besok kita belajar banyak dari benchmarking dari UCLH dan juga dari apa itu namanya, dari Belgia juga.
Oh, bagus sekali kalau misalnya bisa diselesaikan di dalam kandungan ya.
Iya.
Bayinya juga lebih baik.
Iya.
Iyalah, lebih baik di dalam kan daripada nanti dikeluarin baru kita ngapa-ngapain. Infeksinya besar kok. Itu tapi angka kegagalannya?
Saat ini kita belum pernah melakukannya Pak. Cuman kalau data di luar itu cukup menjanjikan ya. Artinya khususnya betul ya. Artinya ketika harapan untuk bisa menekan morbiditas karena neurotoksik cairan ketuban itu sangat-sangat bisa ditekan gitu.
Bagus deh kalau misalnya kita bisa dapat dari didukung oleh dari United Kingdom ya, UCLH. Thank you very much for your support. Atau all your team.
Ya, ini yang terakhir. Ya, sekarang kita sadar bahwa sekarang banyak sekali tenaga kesehatan itu dari koas untuk jadi dokter umum, PPDS 1, PPDS 2, sehingga kadangkala paparan mereka terhadap kasus baik itu yang normal dan tidak normal menjadi tidak adekuat, sehingga kami coba memikirkan bagaimana level kompetensi yang diharapkan itu bisa tercapai. Jadi karena saat ini kendala misalnya karena keterbatasan pasien, karena ya banyaknya peserta pendidikan, kami salah satunya adalah mensiasati dengan alat bantu yang ultrasound simulator ini. Jadi artinya tidak melulu langsung terjun ke pasien, tapi dia juga bisa belajar pakai simulator ini dulu untuk kemudian seperti ini. Dan juga ini contohnya adalah misalnya kayak transvaginal gitu. Jadi kita bisa demo, artinya seringkali yang namanya pasien mungkin merasa tidak nyaman gitu ya kalau langsung, sehingga ini juga bisa mensiasati bagaimana level kompetensi tetap bisa tercapai dengan ada beberapa barrier seperti itu gitu Bapak. Ya, makasih Pak.
Kayak gini
ya.
Jadi dia bisa mengira-ira nanti kalau pakai peluk beneran seperti apa rasanya gitu ya. Kan sambil lihat di situ.
Iya. Oh, ini kalau ngeliat ini. Oh, kalau ngeliat ini.
Belum ada oke-nya, nanti akan ada oke dong.
Sampai dapat oke.
Oh, sampai dapat oke.
Iya, berarti udah benar ngambilnya gitu.
Slow.
Kurang gerakin lagi, puter.
Memang nggak bakat oke nih.
Ini geser kemana nih?
Oke.
Kalau udah oke itu berarti udah benar itu Pak Didi.
Ya, susah juga ya.
Oke. Oke.
Ya, dia udah
Press the space bar. Oke.
Oh,
Okay.
jadi enak
Okay.
latihannya. Oh.
Press the space. Oke.
Oke.
Press the
Wah, enak ya gitu ya. Ini murah, berapa?
Dari
Vendor.
Iya, membantu Pak. Dari GE Pak.
GE.
Iya.
Yang mahal GE mana GE? Ini GE itu selalu mahal-mahal. Wah, jangan gitulah. Berapa?
Untuk edukasi nih.
Untuk edukasi gratis. Oh gitu. Ya kalau bisa jangan hanya harapan kita gitu loh. Kalau bisa semuanya.
And now
ya.
I can
Keren.
measure the CRL by placing one caliper on the ground.
Ya. Saya minta diperbanyak deh, Ji. Si Ren menang apa? Supaya nanti saya minta sekaligus biarin. Iya, oke. Ini bagus nih buat pelatihan ya. Supaya pasiennya kan, supaya kalau ketika dia udah terjun ke pasien juga merasa nyaman ya. Nggak merasa diobok-obok gitu ya. Oke, good. Bagus. Iya. Jadi ini benar-benar lain ya. Ini apa? Ini workshop atau seminar berarti? Workshopnya lain ya. Jadi 4 hal yang mau diajarkan ya. Good. Nanti saya lapor ke Pak Menteri, Pak Menteri ada acara dengan Pak Presiden ya. Nanti saya lapor ke Pak Menteri. Ya, apa? Iya, hari ini luar biasa ya saya ngelihat 4 hal yang baru ya. Saya lihat sangat bermanfaat ya untuk menurunkan angka IMR sama MMR kita ya. Dan saya senang sekali Bapak Ibu semua yang hadir di sini dari seluruh Indonesia ya. Bahkan ada dari Malaysia saya dengar, tapi sayang ya dari Maluku, tadi saya lihat Papua, NTT belum hadir gitu loh. Nanti ke depan saya minta supaya seluruh Indonesia hadir deh ya. Nah, sekali lagi terima kasih ya atas dukungannya. Saya berharap mudah-mudahan ini bisa membawa perbaikan untuk menurunkan angka IMR kita sama MMR kita yang masih tinggi ya. Bahkan mungkin sama Vietnam aja udah kalah gitu. Sedih kita. Kita berharap Indonesia bisa lebih baik ke depannya. Demikian. Makasih. Selamat berlatih ya workshopnya. Oke.
I would like to express our sincere thanks to Mr. Adit for his guidance during the exhibition. Also to Mr. Azhar, Mrs. Sadina, Mrs. Okti, and Mrs. Julia for their contributions and supports. Moving on to the next agenda, we have plenary session 9, with the theme setting up a genetic service that will be presented by Mrs. Sarah Hillman, Mrs. Alice, and Tazin Ashraf. Both Mr. Alice and Mrs. Tazin Ashraf will be joining us online. Thank you.
So this session will be directed by you or this is online? Yep.
Can I check that you can see my screen?
Hello, Dr. Tazin.
Hello, can you see my screen? Am I sharing okay?
No, not yet.
Let me try again.
Oh, wait a minute, they'll check it now. Hello, Dr. Tazin. Sorry for disturbing your weekend. I know this is Sunday.
No, that's okay. Thank you for having me. Looks like a lovely symposium that I'm missing, but Thank you for having me and good afternoon to you all. I'm a consultant in genetics at Great Ormond Street Hospital in London. And I'm talking to you today about the fetal genetics multidisciplinary team clinic that we've set up in liaison with Prof. Pandya and Sarah Hillman at UCLH Hospital. I can't see what you can see, but hopefully my screen is sharing appropriately.
Yeah, we can see your screen.
Okay.
Ah, perfect.
Okay. So just a little bit of background about genetics. We can examine our genetics in different ways. And if you imagine our body's made up of cells, which are like libraries, on those libraries are chromosomes, which are like the bookshelves in the library. And then we have genes, which are the instruction books that are carried on those bookshelves. And over time, the way that we can look at chromosomes has changed. So particularly in the context of prenatal testing, a QF-PCR allows us to look at certain chromosomes, to look for aneuploidy. We can also used to do karyotyping, so that looks at chromosomes, to look for large sort of bits missing or doubled up or whole chromosome deletions or duplications. And then that technology evolved to picking up smaller deletions and duplications on array. And now we can do sequencing on fetal DNA. And we can look at a few studies that have been done in the past. So when you look at the PAGE study, which was a large study out of the UK, we looked at unselected fetuses that had anomalies and had already had microarray testing. And we found that with this, we could pick up pathogenic variants in about 8.5% of fetuses using fetal exome sequencing. And Petrovsky et al. In 2019 did a similar study, but smaller size, and they had a diagnostic yield of 10.3%. But subsequently, we did piloting across our main two centres that do fetal exome sequencing in the UK. And there was this other study from Normand et al. In 2018, which looked at whether adding a genetics review increased or decreased the yield. And we found that in all of these three pilots and studies, adding a genetics review to look for a condition that is likely to be monogenic increased the yield significantly on fetal exome sequencing. And in 2020, the National Health Service started offering fetal exome sequencing in clinical practice. So this is where we will look at fetuses that have multiple anomalies with a high likelihood of them being monogenic and offering fetal exome sequencing for those. And in these boxes are the different conditions that we should consider offering fetal exome sequencing for. I'll just run through some of them very quickly. So fetuses with structural anomalies in several systems, suspected skeletal dysplasias, large echogenic kidneys with a normal bladder, major CNS abnormalities, multiple contractures, nuchal translucency, if it's very high, above 6.5, we would offer exomes for those cases if there's another anomaly. And if the nuchal fold is persistently elevated above 3.5, we would offer exomes if there's structural anomalies in 2 or more systems. And then isolated non-immune fetal hydrops and abnormalities of the corpus callosum, either partial or complete agenesis, either in isolation or in association with other anomalies. There's also a few situations where we'd also consider offering fetal exome, even if the fetus doesn't meet the above criteria, and those are in pregnancies of consanguineous couples where monogenic disorder is considered likely, or in a couple where they've had a recurrence of anomalies in a pregnancy, and although they may not fulfill the criteria because of the recurrence, it's thought to be monogenic. We don't offer fetal exome sequencing for minor markers of aneuploidy, so things like echogenic foci or mild renal pelvis dilatation or mild ventriculomegaly, choroid plexus cysts, etc. those things are excluded unless they're in combination with more major abnormalities. So the system devised in the UK it's a little bit intensive because of the increased yield of adding genetics, and also with all the sort of legal and bureaucracy systems, we have quite a lot of administration involved. But essentially, if a case is identified by the local service or the fetal medicine team, they would discuss, they would refer to genetics and then discuss the eligibility of that case going forward for fetal exome sequencing. And then if the test is approved, then we would collect the samples, do the consenting, and then arrange for the testing to be done. And we thought that rather than having all of these multiple stages, it would make the process much more streamlined if we could have genetics and fetal medicine seeing the patients together in clinic, and then being able to go through the acquiring of the samples, looking at the scans, having the discussion about fetal exome sequencing, doing the consult all in one appointment, and then the sample gets sent off for testing. So just in terms of our fetal exome, because different places are offering different types of tests, we are currently offering a sort of curated panel of 1,500 genes that are associated with fetal anomalies detectable on scan. And this approach will detect about 99% of single nucleotide variants within the genes on that panel, and also up to about 90% of small insertions and deletions. The exome sequencing test is not validated to detect copy number variants, so we can only offer this test if a chromosome microarray is also run in parallel. And the limitations of the testing are, because it's exome sequencing, we're not looking at intronic regions of the gene, so we would miss intronic variants. We would also not detect imprinting defects or triplet repeat disorders or structural variation, or any genes that are not currently on the panel. And the panel gets reviewed about twice a year, where if there's any new evidence of new conditions that can cause fetal anomalies or fetal presentations, they would be added to the panel. And if there's any conditions that are refuted and the evidence is lacking, they would get removed from the panel. So when this testing initially started, we were offering about 1,000 genes, and it's increased to 1,500 in the course of about 5 years. The turnaround time for the testing is approximately 3 weeks. In the UK, the turnaround time for microarray is approximately 2 weeks. So we run these ideally in parallel, so a total time of 3 weeks to get all of the results. And as I said, the consenting process is quite rigorous in the UK. So we counsel couples about the outcomes of the test, and that could be that no cause is found for the anomalies detected. We might identify a variant of uncertain significance. We do not, in the prenatal context, always report variants of uncertain significance. We discuss them at a separate multidisciplinary team meeting with our laboratory, and we only report VUSs if they are thought to be very suspicious, or if there's an additional test we might be able to offer in pregnancy or after birth that would clarify the significance of that VUS. And then, of course, we report significant variants. And we discuss with couples the possibility of non-maternity or paternity being detected, because we run this test as a trio using parental samples where they're available. We also discuss that if no diagnosis is made on fetal exome sequencing, we cannot exclude a genetic diagnosis, and we would want to examine the baby after birth in case there were additional investigations, genetic or not genetic, that may lead to a diagnosis. And the classification of the variants is based on the ACMG criteria and is based on the current knowledge, which could change over time. Certain things can't be detected on antenatal scans, such as autism or developmental delay. Some of our patients are sort of limited in their knowledge about that, so we do kind of warn them about these things. And also genes contributing towards conditions, towards those particular conditions are not set up necessarily to always be detected by fetal exome sequencing. As you may recall, I said that we're only really curating the panel to look for any conditions that may present with anomalies on antenatal scan. And in the rare occasions, we might have actionable additional findings, such as a parent carrying a cancer susceptibility gene. For example, in the case of Fanconi anemia, biallelic variants in particular cancer predisposition genes can cause Fanconi anemia in the fetus, and that might be related to multiple congenital anomalies. But that would by default mean that the parents, if these variants are inherited, carry a cancer susceptibility gene variant, and they may then be eligible for additional screening or treatment. So just to talk a little bit about our service, you've all met Sarah Hillman now, but we run this clinic every Wednesday morning. It's a half-day clinic, and the building is the Elizabeth Garrett Anderson Centre, which is where fetal medicine is based at UCLH Hospital. We started seeing patients face-to-face in October 2020 due to a bit of a delayed setup given COVID. And we triage cases into this clinic if they have multiple fetal anomalies or fetal anomalies that are associated with a high likelihood of a genetic diagnosis, or if a parent or previous child is affected with a particular genetic disorder. Apologies for this being very old data. We're at the moment putting together our new data, but I thought it might be helpful to see a little snapshot of the kinds of cases that we see. So this is from the first year of our service, and we were seeing approximately 115 patients that year. That number has definitely gone up. And we were seeing a majority of them face-to-face, which we still are. There was a few virtual appointments at that time because it was around COVID. And this pie chart on the side just shows that the majority of the cases we're seeing are cases presenting with fetal anomalies. But there are some cases that we are seeing because they've had a previous affected baby or child where a genetic diagnosis may not have been known, and a couple of cases where a parent might have a genetic disorder. And then a few cases that we see for second opinion from other centres in the UK or outside, and a few cases of mosaic embryo transfer following pre-implantation genetic testing for aneuploidy. This is just a screenshot to show you that over time there's been lots and lots of studies in the literature relating to fetal exome sequencing and diagnostic yield. Overall, diagnostic yield based on systematic review and data analysis from the Mellis et al. Paper in 2022 showed a 31% diagnosis hit after a normal or non-diagnostic microarray. And I thought I'd just talk a little bit about skeletal anomalies, because in the literature, these have a higher diagnostic yield. Of course, that makes sense because bones are easy to see on antenatal scan compared to perhaps other structures. And from the literature, the diagnostic yield from prenatal exome for skeletal anomalies is about 53% in the highest quoted paper. And from our cohort in the first 2 years, we looked at all of the cases that had a primary presentation of a skeletal anomaly. So not cases that had multiple abnormalities, and skeletal was one of them, but a primary skeletal presentation. And we found that we had a 90% diagnostic yield. So the only case that we didn't find a genetic diagnosis was a case where the baby had hemivertebra and a suspected congenital diaphragmatic hernia, which may argue is not a very high risk for having a genetic diagnosis anyway. I know that you'll be doing a workshop with lots of cases with Professor Hillman, but I thought it might be helpful just to put into context how we deal with these complicated cases at UCLH. So just some case examples very quickly. This is a case of a couple that were consanguineous. This is their first baby, and the CST was low risk. And in this case, the PAPA was 1.9 and the nuchal translucency was 1.7. The fetal measurements of the head circumference and AC were appropriate, but the baby did have some features of skeletal dysplasia on scan, and those included short, long bones, and we could see bowing of the femora, tibia, fibula, and the lower extremities seemed to be more affected than the upper extremities. There was also mild hypoossification of the skull, and bilateral talipes, but with a normal chest size. There were no other structural abnormalities or markers of aneuploidy, and the amniotic fluid volume was normal, with normal Dopplers. And this patient had an amniocentesis with normal QFPCR and microarray. It's just a screenshot of the kind of report that we produce, the fetal medicine team produce, and you can see that all of these markers of measurements are well beyond the lower centiles. And I'm not a fetal medicine expert, so I can't really talk you through these images in great detail, but even I, with my genetics, I can appreciate the significant kind of deformity of the limbs and the bowing that's seen here, and this is to demonstrate the hypoossification of the skull. So in this case, we offered the couple fetal exome sequencing and identified likely pathogenic, so class 4 variants in a gene called CRTAP, which is a gene that leads to an autosomal recessive osteogenesis imperfecta. And based on that, we were able to counsel the couple about the diagnosis. And in light of it being osteogenesis imperfecta, we were also able to plan appropriate delivery and postnatal care. CRTAP is quite a rare gene, and there at that point had not been that many cases reported in the literature, but we consulted with some skeletal dysplasia and OI experts up in Sheffield about the presentation, and they helped to advise us about the delivery and the postnatal care. And antenatally, we were also able to refer this couple to the pediatric OI service at Great Ormond Street Hospital, so they were able to meet the clinicians and talk about what to expect and how to handle the baby after birth, which I think they found immensely helpful. And then after delivery, the baby has been regularly been seen by this clinic, which is, again, a multidisciplinary clinic with all sorts of therapy support for children with osteogenesis imperfecta. Case 2 is a case of a fetus that had very short, long bones and flexion of the middle fingers, and again had had normal microarray testing and had also had non-invasive prenatal diagnosis for FGFR3, which I think you'll be hearing about NIPD in more detail next. And you can see again on this scan at 23 weeks, the measurements are very low. And here are some of the fetal pictures. This is the limb extremity where the middle fingers could not be visualized very well. And on this occasion, we found a likely pathogenic de novo variant in a gene called TRPV4. Now, this is a gene that's associated with several different genetic disorders. And so we looked through all of these conditions, and metatropic dysplasia seemed like the most likely clinical presentation of what we were seeing on scans that correlated with the variant results. And again, this is another very rare genetic skeletal dysplasia, which means that there's a reversal of body proportions between birth and childhood. At birth, the limbs are disproportionately short compared to the trunk, but then in childhood, the trunk becomes more severely affected due to platyspondyly and scoliosis, and the limbs comparatively then kind of improve in size. This can be a lethal condition, either perinatally or afterwards, if the chest size is very small due to underdevelopment of the lung parenchyma. But infants that survive the perinatal period typically can live for much longer, although they will be impaired in terms of their physical ability, and also pulmonary function tends to be involved. However, these children do tend to have a normal intellect. So after careful counseling with the couple, and the couple did a lot of their own research, plugging into support groups across the world and speaking to other patients affected with metatropic dysplasia, this couple then decided they wanted to continue with the pregnancy. And again, we were antenatally able to refer them to a highly specialized skeletal dysplasia clinic. And so they were able to meet all of the health professionals that would be involved in their baby's care even before birth. And then this baby has been followed up in that clinic. So from a patient perspective, there are huge benefits of the way that we work. It's much easier for patients to come to a single appointment and meet multiple specialists rather than having multiple different appointments. We can obviously consent and bleed patients for exome sequencing at the same time of the appointment rather than then bringing them back. And at UCLH, there's a fantastic multidisciplinary meeting that happens every week. So we're able to bring our complex cases to that meeting to discuss with a wide variety of professionals, including fetal medicine, but also cardiology or surgery. And we can also discuss the eligibility of cases to have a late termination of pregnancy. As well as that, there's genomics education for fetal medicine staff and streamlining referrals to specialist teams at Great Ormond Street, often antenatally, which is, on informal feedback from patients. They really value that input and the ability to talk to people that will be caring for their child after birth to get their specialist perspective, but also to help prepare themselves for what might be coming. There were some challenges initially with the service. So UCLH is a referral centre for patients that fall under two different genetic services, our service and the Northwest Thames Clinical Genetic Service. And at first we were only covering our patients, but this has now changed and we're seeing the Northwest Thames patients in the clinic as well. And although we run the same EPR system at Great Ormond Street and UCLH, they're not linked very well to each other. So that means that there is often duplication of the documentation and letters that we need from a genetic side and from a fetal medicine side. And obviously, given all of the things that would happen in this appointment, we're seeing less patients on average than a standard fetal medicine clinic because of the multidisciplinary team counselling that takes place. And then I guess from a personal perspective, it's also been lovely doing this service because it's so nice to be working as part of a wider and really specialized team. And we have amazing, clinicians at UCLH, and the care that we deliver to patients is something we feel very proud of. So that is all from me. And I hope I didn't go too quickly and that was a useful sort of whistle-stop tour through how genetics and fetal medicine can collaborate and work together.
Thank you. Thank you for your brilliant presentation. We will ask the audience, is there any question to Dr. Tazin? Oh yeah, or Professor Sarah itself.
For Dr. Ashraf, if anyone wants to come and see me in the workshop.
Yeah, okay.
Thank you, Taz. Thank you for making it from the other
Hi,
side of the
Raf.
world. Is there any network, any connection that our colleagues from Indonesia, they can access to in case they have a rare disease like the one that you presented and they need to explore what is the outcome worldwide or to be in connection with? How can you give some tips that it's easy for them to access from here without disturbing you directly, obviously?
Yes, that's a really good question, Raf. It would be lovely to increase those international collaborations with Indonesia and other countries. I think that I need to think about that a little bit. I wonder whether there's the potential to join maybe part of the MDT, perhaps at the end of the MDT, so that, obviously there's some confidentiality issues with us discussing our NHS cases, or even, a research or collaborative MDT once a month to kind of go through interesting cases. I'm not sure whether is fetal exome sequencing being offered regularly in Indonesia, or is that a rare hit and miss? but it's probably something that they're looking to increase their offering for. So yes, we'd be very happy to be involved and help collaborate on those kinds of cases. From my own perspective in genetics, when we do see these rare things, often Alice and I haven't seen them either, and perhaps people in our team haven't ever seen a case. So there's a lot of trolling through the genetics literature to try and identify the presentation and if it fits. But also we're very lucky to have a lab that is extremely accurate. And I think that's one thing that needs a lot of investment from a government perspective, is laboratory services that can very accurately detect these changes.
Yep. Thank you, Dr. Tyson. Really appreciate it. Maybe we will talk it later about this matter. Okay.
Yeah.
Thank you, Dr.
Thank you so much for having me.
Give a big applause for Dr. Tyson. Thank you for your time. Have a lovely weekend. Now we are moving to the next session. Dimitros.
Hello, Dokter. Hello, Dr. Alice.
Hello.
Hello. Can you show your
Can you
slide?
see and hear me okay?
Yeah.
Hello, hold on. A second.
Wait a minute. We still figuring it. Okay, Dr. Alice, can you hear me?
I can. Can you hear and see me okay?
Okay. Okay, you can begin your presentation.
Okay, thank you. Let me see if I can share my slides.
Okay, we
Can you see them okay there?
Yeah, we can see your slide now. You may begin your presentation.
Fantastic, thank you. So thank you so much for inviting me to speak. My name is Alice Gardam. I'm a consultant in clinical genetics at Great Ormond Street Hospital, and I take part in the joint fetal medicine and genetics clinic that's held weekly, run by Dr. Hillman at UCLH. And this morning I'm going to talk to you about our non-invasive prenatal diagnosis, or NIPD, service that we offer in the National Health Service in the UK. So this avoids women having to have invasive procedures during pregnancy to get a genetic diagnosis. So I'm going to talk about what NIPD is and how it works. And then I've included several case studies of patients that Dr. Hillman and I have seen together in our joint clinic. And I'll talk a little bit about the limitations of the testing and also the future potential. So this testing works by looking at cell-free DNA. So when your cells die, DNA is released into your bloodstream. So if we take a blood sample from a pregnant woman, we will see primarily her cell-free DNA floating around in her blood. But from around 4 weeks of pregnancy, we also see the fetal DNA, and that is released from the cells that die in the placenta. And it represents the baby's entire genome. So every bit of genetic material from the baby should be in the maternal bloodstream. We get very low levels from 4 weeks of pregnancy. By 9 weeks, it's very high, and we can reliably test it. So what's the difference between NIPT and NIPD? Well, both of these are tests that use the baby's fetal free DNA that's floating around in the mother's blood. NIPT is a screening test, which is widely available. There's lots of private companies that offer it, and that looks primarily for the common trisomies by measuring the amounts of the chromosomes that are present in the mother's blood. NIPD, though, is non-invasive prenatal diagnosis. So it's a diagnostic rather than a screening test. So if you make a diagnosis using NIPD, you don't need to go on and confirm it like you would with an NIPT test for, say, Down syndrome. And this is only offered in the UK in fetal medicine services or through clinical genetics units. It's not widely available. So there are many uses already for NIPD. The ones I put in red are the ones that I'm going to talk through in more detail today with some case examples for you. So the first group are the generic tests, which are ready to go. We can use them for any pregnant woman if it's relevant. The first is for fetal sexing. So for, if example, a mother is a carrier of an X-linked condition and she's thinking about whether or not to have a test in a pregnancy, we can start by finding out whether she's having a male or a female baby, so that she knows whether or not she needs to then have further testing for the condition in the baby. We can also use a generic test to look at the rhesus status of a baby if we know that a mother is rhesus negative. And then we can use it for the FGFR3 related disorders like achondroplasia or thanatophoric dysplasia, because these are caused by recurrent variants. So we can offer that test to anybody. And then there are bespoke tests which need to be designed with a family in mind. And these currently are used for paternally inherited dominant conditions. So a dominant condition being one where you only need one altered copy of the gene. So if the father carries that condition, we can offer testing to see whether the baby has inherited it. We can also do it for recessive conditions where a baby needs to inherit an altered gene from both parents. At the moment, we can do this for any couples where they carry different variants, and we can look for the paternal variant in the mother's blood. And if it's present, we can then offer an invasive test to see whether the baby has inherited both copies of the condition, both altered copies of the gene. We can also offer this for limited recessive disorders where parents carry the same variant. For example, we can do that for cystic fibrosis and spinal muscular atrophy, although it's much trickier when the parents have the same variant. Now, on the NHS, we wouldn't offer testing for couples whether they have had a baby before with a de novo dominant condition, so one that's a new genetic change in the baby, but patients can pay for this and have it done privately. So, for example, if a couple have had a baby with Noonan syndrome caused by a de novo variant in PTPN11, and they would just like reassurance in the next pregnancy but don't want an invasive test, they can pay to have a bespoke test to look for the PTPN11 variant using cell-free DNA in the next pregnancy. And we try and only offer a test if it's going to change the management of the pregnancy, either because a couple would end a pregnancy or because we need to put in a management plan for the newborn baby when they arrive. So the first example I'm going to talk about in a bit more detail is the FGFR3 related disorders. So half the time we offer this because there are scan anomalies and we think the baby is clinically affected, and half are done for a family history. So either the father carries, is known to have achondroplasia or another FGFR3 related disorder, and the couple want to know if the baby's inherited it, or they've had a previous pregnancy affected by achondroplasia or thanatophoric dysplasia, so we can offer that as well. Most of the gene variants that cause these conditions are recurrent, so at the moment we look for 31 of these variants, and that's thought to pick up every baby with achondroplasia or thanatophoric dysplasia. And there's very strict test criteria to who we can offer it to. I've simplified them here, but the first group are those where we think the ultrasound findings would be consistent with achondroplasia. So normal long bone length at the 18 to 20 week scan, but from 25 weeks on, tailing off of the growth, and relatively big head or frontal bossing. And we can use other criteria like short fingers or polyhydramnios as well if we need more evidence to get the testing approved. Or the second group is ultrasound findings compatible with thanatophoric dysplasia, so all long bones, very small from very early in the pregnancy, and a small chest with short ribs. And again, those other features that we look for, like bowing of the long bones or frontal bossing. So we have to meet these strict criteria to offer it. So this is a baby that was looked after at the UCLH fetal medicine unit who presented with very short long bones from the 20-week scan. And there was bowing of the long bones and polyhydramnios, and a diagnosis of thanatophoric dysplasia was suspected. This couple wanted the diagnosis confirmed, but didn't want an invasive procedure if they didn't need one. So we offered them the NIPD for the FGFR3 related disorders at 24 weeks of pregnancy. And unfortunately, this did confirm that the baby was affected by thanatophoric dysplasia, and the baby had one of the FGFR3 variants that we know is associated with thanatophoric dysplasia, and they made the difficult decision to end the pregnancy. They would then be eligible to have this testing again in future pregnancies. The next group that we commonly offer NIPD to is where a father is affected by an autosomal dominant condition. So for example, neurofibromatosis would be one my parents often do request a prenatal test. So you can see here the mum and the dad that we have using blue lines to denote a normal gene and a red line, an abnormal gene with a harmful gene variant mutation in it. So if you do free fetal DNA and the baby is unaffected, you will not see the paternal mutation in the testing. But if the baby has inherited it, the paternal mutation will be there. So that's a relatively straightforward test for the laboratories to do. And I've got two cases for you which show how useful this test can be. First is concerned about the baby, and genetic testing showed that they had a variant in a gene called ACVRL1, which causes hereditary hemorrhagic telangiectasia. And actually we found the same variant in the father, who was very mildly affected and just had a history of recurrent nosebleeds and nothing else. And it is a very, very variable condition. And really sadly that baby died in the newborn period. We saw them again in their next pregnancy, and they were very keen to know really early on whether or not the baby had inherited hereditary hemorrhagic telangiectasia. So we offered them NIPD about 9 or 10 weeks of pregnancy, and we could not see the variant that the previous child had. So we knew that the baby was unlikely to be affected, and they continued the pregnancy and had a healthy baby. And I've included this because this is a family that had just delivered last week, so it's really fresh in our minds. So this is a couple whose first child was affected by long segment Hirschsprung disease. So the nerves in the bowel hadn't formed correctly, and unfortunately it was quite a late diagnosis in their first child. So he'd gone home from hospital, become very unwell at home, and needed to be rushed back to hospital with bowel obstruction, and had major surgery, and was in the neonatal unit, intensive care unit for a long time. And they had a really rocky start to life. We tested that child and we found a RET pathogenic variant, and that had come from dad. This is a reduced penetrance gene, so often people carry variants in the RET gene without actually having Hirschsprung, but having a variant definitely predisposes you to having it. The father himself had not had Hirschsprung himself, so it was a surprise for him to find out he had it. So we saw them again in their next pregnancy. They would not have terminated the pregnancy if the baby had RET, but they were very keen to know whether the baby had inherited the variant. So they had a bit of more warning this time about whether or not the baby would be susceptible to Hirschsprung disease. And we offered them NIPD at 10 weeks in the next pregnancy to look for the paternal variant. And unfortunately it was there. So their second child had also inherited the RET variant. But this was very helpful because it let us put a management plan in place for the baby. And unfortunately, they didn't pass meconium. They were transferred very swiftly to Great Ormond Street Hospital and had surgery very early. So it was a very, very different situation to the one they had been in last time, because there was a really good plan in place for the baby. Things were picked up very quickly. The surgery was done very quickly before the baby became very unwell. And she's doing extremely well and will be home this week. So it was a very different experience for them because we could offer NIPD. The Next group of conditions are the recessive conditions where parents carry different variants. So we've labelled them here with the normal genes in blue and the gene with the pathogenic variants in red for the dad and yellow for the mum. So we know that when we test the mum's blood, we're going to find both the normal variant and the altered variant in her blood. We know that, but what we shouldn't find is the paternal pathogenic variant. So if we do cell-free DNA testing and NIPD in the pregnancy, and we see that the variant from the dad is there, we know that he has passed the harmful variant on to the baby. We cannot tell whether or not the mum's variant has been passed on very easily, but then we can offer an invasive test. So if we find the pathogenic variant from the dad, then we go ahead and offer a CVS or an amnio to see if the baby has also inherited the pathogenic variant from the mother. If we don't find the pathogenic variant from the father, we know the baby won't be affected and they do not need an invasive test. This baby was given a diagnosis of Meckel-Gruber syndrome. So at their first dating scan, multiple problems were picked up. So the baby was found to have an encephalocele, they were found to have polycystic kidneys, and they were found to have post-axial polydactyly. And we thought it was very likely that this was Meckel-Gruber, and the parents ended the pregnancy based on that. They then went on to have whole genome sequencing, and we were able to identify variants in the CEP20 gene in the affected fetus, and both parents were carriers of different variants. In the next pregnancy, they were very keen to know very early whether or not the baby was also going to be affected by Meckel-Gruber, but were again keen to avoid an invasive procedure if possible. So they were offered NIPD at 9 weeks to look for the paternal variant, and it wasn't there. So we could say straight away, and by 10 weeks, they'd had a result saying that the baby was very unlikely to be affected by Meckel-Gruber syndrome, and they continued the pregnancy and had a healthy baby. Autosomal recessive disorders where parents carry the same variant is much trickier, because we know that the mum's abnormal variant is always going to be floating around in her bloodstream, so it's difficult. So what we don't do is look directly for the variant, but we do something called haplotype analysis, which I'm going to explain with pictures. It is quite complicated. To do this haplotype analysis, you need DNA from an affected child or an affected fetus and both parents. On the moment, at the National Health Service, we can offer this for cystic fibrosis, spinal muscular atrophy, and congenital adrenal hyperplasia. So I'm using an example of a baby who had cystic fibrosis. So their daughter had the common delta F508 variants in both copies of the gene and was affected by cystic fibrosis. And we knew that both parents were carriers with one normal gene and one with the delta F508 pathogenic variant. So haplotype analysis looks at thousands of single nucleotide polymorphisms in the regions of the DNA around the gene. So these are naturally occurring variants that we all have in our DNA. Be thought of as a unique fingerprint or barcode for that region of the DNA. And we can create this barcode or this fingerprint or this haplotype, as we call it, for the affected child and both parents. And therefore we can work out which haplotype is associated with the normal gene from mum and dad and which is associated with the abnormal gene from mum and dad. So this sort of the dark brown stripe haplotype is the bad gene from mum, and the dark blue is the dad's bad gene, and the light colours are the unaffected or the healthy variants. So there would be 4 possible haplotypes in any future pregnancy. So an unaffected baby would have the light brown and the light blue haplotype. Carriers would have either the dark blue or the dark brown, but not both. An affected fetus would have the dark brown or the dark blue. And the testing that we do using the NIPD measures the amount of each haplotype. So it's really clever. It's called haplotype dosage. So you literally see how much of each haplotype is present. And again, you would get 4 distinct patterns, always floating around in the mum's blood. We are going to have her unaffected haplotype, which is the light brown, and her affected haplotype, which is the dark brown. But as I've said already, there are 4 possible haplotype results in the fetus, and those add up together and I've circled the affected fetus so you can see that they've got a dark blue haplotype, so we know they've inherited the altered gene from the dad, and they have got a high amount of the dark brown. So some of that will be mum's floating around in the blood, but some is the baby's as well, and we know that that baby is affected. So it's a very, really complicated but really clever way of saying whether or not the baby is affected or not. So there are some practicalities when doing the NIPD testing. So it needs to be special blood tubes. We generally offer it from 9 weeks of pregnancy, but if so, we take samples 2 weeks apart. After 9 weeks, we take all the samples in one go, and it needs quite a lot of blood actually. So it needs 20 mils of blood compared to your normal genetic testing, which needs 0.5 ml, so it needs quite a lot. And if it's going to be a bespoke test, then there is a bit of setup time, ideally 6 weeks to set up a test. The lab can do it a bit quicker if someone's already pregnant and it's urgent. So the limitations are the timing. So if somebody presents already 16 weeks pregnant, it's hard to justify setting this up and doing the testing because they're already very late in pregnancy when we can test. We can't do NIPD for all variants. So if we can do it for variants where one nucleotide is changed for another, but if there's a big chunk of DNA missing or extra, we cannot pick that up reliably. At the moment, we're only offering it for a limited range of recessive conditions where couples have the same variant. And that can be tricky in parents where they are related to each other by blood because the haplotypes can be very similar in the couple. And it's tricky also in multiple pregnancies. So it's not always available to every couple. There are a lot of future potentials, and our lab is doing lots of research to develop new ways to use the testing. So the first will be a direct test for recessive disorders where parents have the same variant. So instead of doing that very complicated haplotype analysis, they will be able to look directly for the variants. And this will be, again, measuring the relative amounts of each variant. So we've labeled here the normal gene in blue again and the altered gene in red. We know that if the mum is a carrier of a recessive condition, she will have roughly half normal and roughly half abnormal floating around in her blood. And there's 3 possibilities in the baby: a healthy carrier, neither variant inherited, or both variants inherited and they're affected. And you can see on the right there that if the baby and the mum are both carriers, you would roughly have 50% of the normal gene and 50% of the altered. If the baby hasn't inherited either gene, then they will have more of the normal gene present. And if the baby is inherited both altered copies of the gene from mum and dad, in the mum's blood, when you look at the cell-free DNA, you'll have a higher amount of the altered gene. So we know in theory it works, but it hasn't been so reliable that we feel comfortable to offer it just yet as a test. The other future potentials would be to offer this sort of testing for copy number variants, so small bits of missing or extra chromosomes. So the testing at the moment is not reliable, but it's something we'd like to be able to offer in the future. So for example, there are private companies that do screening for things like DeGeorge syndrome, so 22q11 deletions, but it's not reliable. And we'd like to be able to offer diagnostic tests for that in the future. And I said right at the beginning that the baby's whole genome is there in the mum's blood floating around. So we, in theory, would be able to offer whole genome sequencing. So we could either do this if there is anomalies picked up on the scan and we want to make a diagnosis in the baby. So in theory, we may be able to offer whole genome sequencing through NIPD instead of offering an invasive test. We may also be able to use it for screening for treatable conditions. So treatment can start at birth. So instead of doing the newborn screening that we offer now to look at conditions, we normally get results at a couple of weeks of age and then start treatment. Could we make those diagnoses of these metabolic conditions during the pregnancy so that the baby can start treatment at day 1 of life? So all these things are potentially possible, but just not at a stage that we can reliably offer them yet. So in summary, NIPD is already enabling many women to avoid a miscarriage risk of an invasive test by giving them a very accurate genetic test during a pregnancy using just blood samples from the mum. It's already in widespread use for dominant conditions and recessive conditions where parents carry different variants. And there is huge potential for this to reduce the need for almost all invasive testing in the future for genetic testing. I'd just like to thank our laboratory based at Great Ormond Street Hospital, who offer this testing and are very involved in the research and development of new ways to use NIPD. And I've just put my email address there in case there are other questions that come up afterwards that anybody wants to ask. Stop sharing. Thank you.
Is there any question from the audience? Okay, maybe I want to ask about. Oh, okay.
No, you please.
Okay. You mentioned using NIPD for the rhesus, yeah, because maybe in England the number of the negative rhesus D is quite high, but in our country is most of our population have positive rhesus. But in our country, maybe it's the similar. We should do the NIPD like that, the thalassemia. Yeah, yeah, because we can check the parents, the thalassemia gene, and we can use the cell-free fetal DNA. But do you have any experience doing the thalassemia or the fetal do as NIPD?
So we don't, usually because